Hello and good afternoon. My name is Gary Lucas, and I am Vice President of Education for the Association for Rural and Community Health Professional Coding, known as Arch Pro Coding. We're here today through the RCOR grant, the Rural Communities Opioid Response Consortium grant, where the technical and training assistance is performed by JBS International, and we here at Arch Pro Coding provide all the training on documentation, coding, and billing, and helping you optimize reimbursement for substance and opioid use disorders, particularly those of you that are operating and providing medication-assisted treatment. Now, you see that we referenced a focus on community health. Our entire organization is focused on providing training, certification, and audit support for those of you operating in rural and urban health professional shortage areas like rural health clinics, like federally qualified health centers and critical access hospitals and small rural hospitals. But the documentation and coding guidelines that we may be sharing in this presentation are going to be consistent across traditional doctors' offices to those who are in the health professional shortage areas that we in particular speak to. It's when you get to the billing requirements that you'll see the most marked differences in how each facility gets reimbursed. So though we recorded this a couple weeks ago, I will be present at the end of the session in order to answer any questions via live Q&A. But should you need to reach out to me via email, here's my email address for you. And as you see a little bit about my background and educational experience, I've had the wonderful opportunity to teach about 1,900 courses in 46 states over the past 26, almost 27 years now. And we sincerely appreciate the opportunity to help today. So this is actually a 4-hour course that we offer through JBS International, through the RCOR grant. But what I'd like to do as I get started is briefly identify a couple disclaimers and disclosures, of course, because of the nuances and complexities that we have in our various participation contracts with Medicare, with Medicaid, with commercial insurance companies, etc. It's going to be recognized that there are not only facts to present today, and I will give you access to many resources that will give you those facts, so that it's not some guy in Atlanta that put it on PowerPoint, so it must be true, but rather actually providing you information from the sources themselves. But I will be mixing in opinions on how workflows should exist between the major 3 target audiences that we like to focus on, and that is clinical providers, facility managers, and coders and billers. So as we go through this, of course, nothing in this presentation should replace any legal or consulting guidance, but that's where we want to make sure we're accessible via Q&A after the session or even down the road. It should not be shocking to know that sometimes some of these hyperlinks could change and some of those reimbursement rules may differ from each other. And we ask that you keep these slides internal to your organization. And should there be a desire to have some more full training on this subject, we'll tell you how we can do that at the end of the Q&A session. You will hear numerous references, by the way, to the CPT book, to the HCPCS Level 2 code book, and to what's called the ICD-10 book, of course, everybody's favorite. Now, in that CPT manual, please do realize that the CPT book in particular, and I mean the printed manual, unless you actually have the full PDF of the entire CPT book, is the only place where you will locate the documentation guidelines that covers the entire spectrum of providers type and will provide you with the background knowledge you need, for example, to understand how to select a level of office visit. So having the printed version of these CPTs is vital, as software simply does not contain the same educational value, for example, on some of the services like your screenings and brief interventions and referrals for treatment that you're performing prior to the induction and maintenance phases of medication-assisted treatment. You heard me earlier mention our 3 target audiences, and although it may feel like I have the left-hand side being under more internal control compared to less internal control, we will help show that the more your providers are aware of the official guidelines that are, again, only found in that CPT book, where the ICD-10 guidelines marks about 40 pages of valuable information before you even look at an ICD-10 code that likely starts with the numbers F10 through F19, which identifies what your providers are documenting in the medical record as a substance or an opioid use disorder. Many providers may not have seen, especially the more recent, but seen and been trained on the guidelines. Rather, it's understandable they get trained on the EHR and the various IT systems they have to use that does not always match what the documentation guidelines are. Therefore, we need highly informed facility leadership who's aware of the need for the clinical providers and the billers to join together, and that manager is overseeing both the clinical goals and the business and revenue goals of the facility. And in particular, our focus here is on understanding how different insurance companies want the same service to be billed, sometimes on different claim forms than each other, and often without common billing guidelines. Rather, there's different guidelines for each insurance entity. So we hope that by identifying the need to code each encounter fully, irrespective of each insurance company's rules, especially those of you in rural health and community health centers, that being RHCs and FQHCs, will be able to identify on your encounter form what your true costs are, because those RHCs and FQHCs have something every year that the rest of you don't deal with called a cost report, where we're going to capture many things that we don't get reimbursed for, like a nurse visit, like Medicare doesn't pay an RHC and an FQHC a 99211, but we still capture it, we still code it, we still put it into our system, and it may generate additional payment at the end of our fiscal year. So clearly the focus of the billing department there is to get 100% of the revenue, but not any more than we're allowed. And we'll focus on each of these 3 groups and giving each of you some information that will be beneficial. So recognizing this is a pretty high-paced session, I wanted just to identify for those of you that might be new to community health centers. And I was told that there are many federally qualified health center providers and folks in management and coding and billing attending this session. Well, the interesting thing is you often use different claim forms than those coders and billers that used to work in traditional regular doctor's offices. You're having to learn how to use a claim form usually associated with hospital billing. And even for those established veterans that have been in the industry 10 to 20 plus years, when you get to an FQHC and you have to report claims on what's called the UB claim form, also called the CMS 1450 form, the electronic version of it's called the 837I form, there are completely different rules and guidelines for how we report services to Medicare and, as you see, some Medicaid carriers. I will even show examples of substance and opioid use disorder work from both the primary care providers and the mental health providers on both claim forms. Some want what's called the CMS 1500 form, and others want the 1450 form, and that's going to be extremely important. You have different rules related to how you have to bill, or what's called split bill, diagnostic tests between their technical and professional component. So each one of these, I just wanted to put that outline idea that things are different in community and in rural health. Coinsurance is likely not 20% of the allowed amount. You're going to get fixed encounter rates. If you're in a rural health clinic, you're going to get what's called the all-inclusive rate if you met the definition of what's called a valid encounter. And we will together go through that shortly. But it's called an all-inclusive rate. If you're in an FQHC, you don't get paid fee for service. You're likely going to get paid by Medicare and some others under what's called a PPS rate, a prospective payment system rate. So again, we document consistently regardless of insurance. We extract the data from the encounter and code that service consistently across all provider types. But when we talk about billing, it can be a different claim form with a different system where, for example, in an FQHC, the deductible doesn't even apply, but it does in a rural health clinic and, of course, other facilities. Now, the benefit of operating in a community health center is we have more flexibility with our physician assistants and nurse practitioners and psychologists and clinical social workers, meaning that in the majority of scenarios, we get full provider reimbursement, even though it was not a physician performing the service. So whether you are owned by another entity, meaning provider-based, or you are your own independent clinic or an independent health clinic, that can change some of the billing. So during the live Q&A, if you are a rural health clinic, please do let me know if you're what's called provider-based or independent. And then something that was unique to rural health clinics and federally qualified health centers is that idea of the annual cost report, where we often give them data about services we did not get paid for that could generate payment at the end of the year, as opposed to close to that date of service. So some key CMS resources to review, specifically to FQHCs and rural health clinics, are both chapters 9 and chapter 13 from the claims processing manual and the benefits policy manual. And there are others here, such as the one up here, chapter 18, where Medicare describes things like the Welcome to Medicare physical or the annual wellness visit, at which time Medicare has released several documents, one of which I'm giving you a link to later in the presentation, that identifies that that is the appropriate time to perform screening for substance and or opioid use disorders. If you're looking for information on evaluation and management services, which, by the way, is the primary vehicle by which your primary care providers are performing most of your medication-assisted treatment encounters, they received the first update since 1992 last year. So I've provided a little link that you can access via your PDF of the slides to help give those summaries. And as a matter of fact, yesterday, I saw an email about some 2023 updates that are coming down the road. So the bottom two resources to help give you a background set of links to build a self-study binder, in addition to what we're talking about today, identifies some of the new and expanded flexibility on the bottom left side of the slide there for telehealth. And that was last updated here in January, as well as some other COVID-related frequently asked questions. So here's a brief overview of each of the sections we've included here. And again, we've had to make this a kind of a shortened version and an understanding of the limited time we have. So the first section, I've selected highlights from our full course on initiating, staffing, and managing the various revenue cycle activities that will help give each target audience member perhaps a different view of how their work impacts the others. Will help providers get a vision of how billing changes based on insurance carrier. Will also give the billers an understanding that if they're going to look at the medical record, that they understand the various phases of medication-assisted treatment and what those coding opportunities are, and for the managers to help manage varying provider types who, for example, like licensed professional counselors, or licensed social workers, not clinical social workers, on how they may be viable, reimbursable members of your clinical team for some insurance companies, but maybe not Medicare. And that transition over here into the foundations of documenting, coding, and billing, we'll talk about how the patient's insurance type could change some of the billing issues. What is an RHC and FQHC valid encounter to get what many people call their per diem rate, but I don't like it being called a per diem rate because medication-assisted treatment is a perfect example where it is likely that both a medical professional does a medical visit for substance abuse and a mental health professional does another encounter on the same day. And in most cases, that would only be reimbursable as one encounter. But because it's a medical and a mental health encounter, Medicare will reimburse two encounter rates on the same day if we properly have, if we have good billing structure in place there. And we'll review some of the common CPT and HCPCS codes you're using and give you the ability to track and monitor how various providers, those who are licensed or not licensed, might be tracked and potentially included in future contracts you sign with carriers. That could include somebody like a peer support specialist or a peer recovery coach. And we'll give you some good info there. To finish this, these two sections up, folks, now we'll go to the diagnostic documentation, where this is an area your providers need to be most aware of. And that is, although they are going to complete their clinical work and document their clinical work in the medical record, most providers that are screening the patient or providing brief interventions or referrals for treatment are doing so from what's called the Diagnostic Statistical Manual of Mental Health Diseases, 5th edition. Should be pretty darn close to that. And based on their clinical work, they may end up writing or typing in that medical record, this patient, based on the DSM-5, has a substance use disorder or an opioid use disorder, but the ICD-10 book does not contain those words. So how do we create a crosswalk between the terminology clinicians learned in medical school, if you will, compared to those that need to go to claim forms that don't state use disorder, but rather likely, depending on the substance, has what's called either use or abuse or dependence, even though the more recent versions of the DSM in some cases combine abuse and dependence into one clinical term. The ICD-10 likely keeps them separate. And we'll end with a little summary of each of the sections of those diagnostic codes from F10 to F19, and some of the information providers may not be able to see in their EHRs when trying to assign a proper ICD-10 code. We'll then end up with a couple slides there as far as documentation guidelines for medication-assisted treatment across the various phases, including some how you document your psychiatric diagnostic interviews and or concurrent psychotherapy there. So let's jump into the first chapter here and identify those key SUD, OUD, and MAT phases. Although you heard me mention the screenings, brief interventions, and referrals for treatment, there are a variety of tools you can use other than what you may have heard of as the structured SBIRT tool. So there are other tools that can be used in that initial phase. But once the patient has provided consent or their guardian has provided consent and has been told they now are subject to routine or random drug testing, etc., we begin and induce the medication of choice, stabilize them, maintain it, and of course hope to reach early, partial, and or sustained remission. So when we get to the possible CPT and or what are called HCPCS level 2 codes for those screenings, you may be using the DASH tool or the Cage Assist tool or others. But the key is that that encounter or those encounters resulted in the establishment of an ICD-10 code where the documentation guidelines are met. And then for the first week or so, where the clinician is introducing Suboxone, buprenorphine, naltrexone, naloxone, a variety of the approved medications, that clinician is going to identify the proper dosage, and then over time, the ability of the opioid to have any impact or as much impact as it had on the patient in the past is reduced or eliminated, and then the medication we've been using to help with those, in particular the opioids there, begins to be phased out. And even though your providers may be documenting either early or partial or sustained remission, folks, it should be noted that only a few of the various categories of ICD-10 codes get into those details. So again, clinicians may have a different terminology than those on the billing side have, and we need to create good, effective communications between both of those groups. And I think that's done through an informed manager who can help balance the needs of both, again, the clinical and business side. So we've gone here to SAMHSA there. Anytime you see a yellow star on the slides here, that is the highlight, the hyperlink itself is not the yellow star, rather whatever picture I'm bringing. In this case, brought to you by SAMHSA, the Substance Abuse and Mental Health Services Administration, where I did a little cut paste job here. There's actually a heck of a lot more to help those that might be new to medication-assisted treatment, regardless of where they are in the facility, in order to identify the various meds that are used, whether it's for alcohol use disorders or opioid disorders. Notice that methadone is touched on here briefly on slide 13. You are likely not providing methadone unless you've gone through the process of going through SAMHSA to be recognized as an OTP program, all right, an opioid treatment program. Yes, I know y'all have, I live in Atlanta, I'm gonna say y'all. Yes, I know that y'all have a treatment program for patients on opioids, but an OTP program is a separate designation through SAMHSA. And if you hear OTP program or see different coding or billing options when you're doing your internet research, make sure to recognize that that is a very specific designation, not a generic term for those that are treating patients with opioid disorders. So, although methadone was mentioned there, the reference to SAMHSA and the OTP programs is on slide 14. But keep in mind that buprenorphine may only be prescribed by someone who has achieved or completed, I should say, 8 hours of training if they are a physician, or up to 24 hours of training if you're a PA or an NP. And getting that training means you earned a waiver. There are various names: an XDEA waiver, a Data 2000 waiver. Now, getting buprenorphine into patients' hands has been a tough thing in rural areas because of the need to go get this additional training. And of course, with the public health emergency, having that time is very difficult. But there has been positive news and the ability to expand buprenorphine to others without getting that training. And I know this sounds odd, by asking for an exemption from having to get a waiver to provide buprenorphine, which is an evidence-based treatment, of course, and likely one of the more common drugs that you're using in your opioid abuse and opioid dependence work. So I have good news here. If you are a rural health clinic provider, or you have a provider in your federally qualified health center that did get their waiver, the Data 2000 waiver, since January of 2019, you can go to a couple of these sources to locate the information that would literally give you $3,000 per provider if they got their data waiver since January of 19. This was or is a first come, first served issue. And to my knowledge, I think there's still some money in the pot there. I would highly recommend you follow one of or both of these hyperlinks, from the RCOR monthly technical assistance newsletter to the one where it was mentioned on the left, and even a HRSA, Health Resources Service Administration site there. This webinar may have just generated good revenue for you. Now, that said, there have been additional pieces of good news to expand buprenorphine to those providers, all right, who may want to have immediate or more immediate ability to give buprenorphine without going to get that waiver that would allow them to treat up to 30 concurrent patients with buprenorphine. What we've presented for you on slide 17 may take you to a couple different areas, whether it's going to SAMHSA's website to look at a summary of these guidelines and how to become one of those waivered providers. Or if you really need to go in depth to what's called the Federal Register, where the initial proposals are published and what the public comments were and what the final decision from SAMHSA was, there's the most in-depth, probably too deep than is needed, but full source document and the form you would need to fill out to become an exempted from getting a waivered practitioner is the third bullet there. And an organization called California Bridge, or the Public Health Institute, has a nice website where they have little brief videos on helping you fill out the forms and some of those things that should take about 60 days to be approved, but would then expand your ability for that first year to treat up to 30 patients, buying you time to get that waiver, would allow you then to go up to 100 concurrent patients. Whether those numbers are needed or reasonable in your area should just be noted. Sometimes that 30 patient limit may be enough in a lot of the rural areas we work. So as we continue, please notice and join me on slide 18. What we've done here is given you access to a checklist that would help you identify a way to, outside of the RCOR or Rural Communities Opioid Response Program, the RCOR grant, but just be able to take a general look at employee access, staff retention, workflow, credentialing, and what I've selected here is just a brief piece of financial and regulatory readiness. And rather than look at this as, hey, are we not ready for this? Are we in progress or ready? You can change those terms to whatever you need, whether you're initiating your MAT program or you're maintaining it over the long term. And what you'll see in here should not be a surprise, such as the idea that coverage for medication-assisted treatment varies from state to state in both the public sector, Medicare, Medicaid, and private insurance marketplaces. So although you only see two questions here, such as what formulations of the drugs would your carriers provide? Are there limitations on medications that we use in this area? And I recommend highly that you access this full checklist as a kind of a checkup, if you will, on your program. So as I give you this unfortunately true but correct statement that Medicare billing will differ from Medicaid, which will differ from commercial insurance, which may differ from blank, please recognize the need following this course to go gather details on your Medicaid policies. And here in Georgia, by the way, we have 4, if not 5 different Medicaid programs. So researching Medicaid as a whole, let alone the individual billing requirements that often come in your Medicaid behavioral health manual, you will see differences. But again, as long as you look at documentation and coding as being consistent among provider type and irrespective of insurance type, The billing is going to be greatly different. Therefore, in this presentation, I'm going to help provide you options and alternatives to some codes that may not be working when you build those insurance entities, because there are different things out there. So I applaud you having your state folks and those associated with the public health districts providing this education. But folks, quite honestly, expect there to be differences on billing options. So for anybody that says, well, wait a minute, I thought we have to bill everybody the same, that is factually incorrect. What you have to do is charge every patient the same. So I'll show you some codes later. There are codes 99408 and 99409 that are time-based codes for performing a structured screening for alcohol and substance abuse. All right. Well, there are codes G0396 and G0397 that have alarmingly and strikingly similar definitions to those CPT codes. But if one of those has been working, maybe the carrier changed their policy and they now want the other code. I don't remember getting many phone calls from insurance companies saying, hey, I know these codes in the past work, but we now need you to use these other ones. And I know it definitely doesn't work when you have billers going to appeal claims, because if you say, hey, you guys aren't paying the same code you've paid in the past, what do we need to do to properly get reimbursed? It is almost guaranteed that on the phone, that insurance company says, quote, I am not allowed to give billing information out. So we will provide options here, as well as some background guidance to help you continue to push for ongoing advances at the state Medicaid level. Because anytime you see Medicare putting out something that says mandatory Medicaid state plan coverage of medication-assisted treatment that requires the plans to pay for MAP, this letter is something that's public. And so when you get a chance to, or if you wanted to review it, I've picked out some areas that at least to me were interesting, such as on page 1, that any updates to behavioral health or telehealth or which formulations of medication-assisted treatment are covered, that those benefits were supposed to go back to October of 2020. If you need information as either a manager or a biller on what the difference is between an opioid agonist versus an opioid antagonist, they give some good clinical information here. They break down that peer support should be a viable issue and that's reimbursable in medication-assisted treatment. A peer support specialist is somebody that is likely not licensed or credentialed as a medical professional, but has achieved training and maybe even certification as an individual that's gone through this on their own and wants to be a helpful member of the team. Well, there is one code in the HCPCS Level 2 code book, H0038, you'll hear me reference earlier. The unfortunate part is H codes are reserved for Medicaid. There may not be codes for other carriers. This is where the billing side can get a little bit goofy. So whether it's expanding telehealth or otherwise, this is good source information. And although it came about in November of 2019, folks, there is a 50-state scan provided by the National Academy of State Health Policy, where they researched provider and billing manuals and state regulations and may be helpful in helping you identify how you may utilize non-licensed professionals and see if and how they could become reimbursable members of the care team. So we've got about 15 more minutes to go. What I've done here, especially for those at an RHC and an FQHC, is identified that in order to get your all-inclusive rate or your PPS rate, you have to have a face-to-face visit with an authorized provider that meets medical necessity guidelines and is done in an authorized location. So that comes from Chapter 13, and that's where you're going to find the idea that you can get reimbursed for both a medical and a mental and health service on the same date. But what I want to do is give managers and providers a quick visual about how each of the forms that are used changes how your providers and billers communicate via the super bill or the encounter form or the charge ticket or the routing slip that used to be a piece of paper where the providers circled what they did and why they did it. They gave that to the patient who took it out to the checkout counter. Now that's electronic. But in particular, what I'd like you to look at on the left side is how if we're billing an insurance company where we're expecting fee-for-service payments, we're going to use the 1500 form where you see the ICD-10 codes are in the top. This what did we do codes are on the bottom, but it's the area with the yellow star. It's how do we link those diagnoses together in order of importance that is going to be used to show, quote, medical necessity. And if I have both a medical provider doing their work and a mental health provider doing their work on the same day on the same patient, they each send out a 1500 form. Totally different over here. For those of you in FQHCs or rural health clinics, when you're expecting that daily rate, well, in this case, the what did you do codes go on top, the why did you do it codes go on the bottom, and never the twain shall meet. They are not linked. So you get the idea that if I'm a biller, especially using the claim form on the left-hand side of the screen, I need to know which of the 2, 3, 4, 5, 6 diagnoses you gave me is the primary reason for each service. Let's show you an example in more detail coming up and where many of your claims are getting denied. Compare that to the right-hand side of the claim form where I'm not really even being too lackadaisical here. You throw everything you did up top, you throw the why did you do it below, excuse me, and assuming you've met the basic billing rules, you should get reimbursed. So a sample fee-for-service claim for a primary care provider that's giving a shot might contain diagnoses for opioid dependence, depression, and obesity. At the bottom, we did a level 4 office visit, and we gave an injection of a drug. The drug identified for buprenorphine here is J0592. Whoops. But the key thing here is that my medical provider is using opioid dependence as the primary diagnosis. Now, had we switched or flip-flopped those diagnoses, whatever I'm doing, whatever order they're in, doesn't matter as much as what I'm putting in this block. Because if this provider used depression as their primary diagnosis, or in the example that I just kind of have up here now, and let me get rid of some of the ink here, that if I use depression as the primary diagnosis, claim denied. If I happen to use obesity, it would still get paid, but I bet obesity won't cover the drug used for medication-assisted treatment. So again, had I flip-flopped these two, no problem. But this down here should have read B, comma, A, so that opioid dependence is the primary diagnosis used for the visit, and opioid dependence is the primary reason for the injection. If you flip-flop those letters or give somebody in billing a bunch of CPT codes and a bunch of diagnosis codes, they often have to guess. Because the provider may not have completed their note yet. No fault there. But if the biller goes to look at the note, the provider hasn't closed it yet, they don't know. And if they go ask the provider, let's just say it's not often easy for a biller to get routine access to providers. Here's the sample fee-for-service claim for a mental health provider who did 30 minutes of therapy and filled out another health or behavior assessment. The key here is that whatever order the diagnoses are in, that now the mental health provider did use the mental health diagnosis depression, followed by the other diagnoses identified in the note, like opioid dependence, that affected their service. Now, the idea that they did another assessment is identified with that Z code. But again, as you flip these letters in block 24E, that in my 27 years of experience is responsible for over 50% of your claim denials. Now, had I been a rural health clinic, and I'm going to put everybody's services on one claim form, that's what I do. I put the office visit, the injection, and the J code down there with a RHC specific modifier, different talk for a different day, CG. Then I put the therapy and I put the behavioral assessment down as well. All of the diagnoses go on the bottom. I don't need to link them together, and I should get 2 different encounter rates. Similarly, those of you in FQHCs have some very unique codes I've highlighted in red that nobody else listening to this class will need to use. These are FQHC only billing codes that identify that if you're going to pay me for a medical visit for an established patient, GO467, or a mental health visit, GO470, that the services that we provided were on what's called a qualifying visit list. Well, a level 4 office visit qualifies me for a PPS payment. Below the GO470 for an established mental health patient visit, 90832 is on what's called the qualifying visit list. And just like at the rural health clinic, we don't link diagnosis codes. We should generate 2 encounters. Folks, that shows how wacky reimbursement is for rural and community health. And we have to sometimes change the code. So to locate good information on Medicare claims processing for RHC and FQHC claims, I've given you the link earlier, chapter 9, and there's going to be some helpful claim examples there. As we wind down, folks, I'm providing you sample CPT codes, such as the insertion or removal of a non-biodegradable drug delivery implant. That's not really, I'm not seeing that as much, but don't forget that J codes don't just include injectable drugs. In this case, would get you reimbursed for the implant itself. And while there are drug testing codes on the left-hand side and giving an injection and office visits, there are often different codes, like the G codes on the right-hand side for some virtual communication services that could be different based on the carrier. The bottom, there may be modifiers you need to place on your medical provider's claims indicating that it was done as a part of a substance abuse or opioid program. Similarly, behavioral health has various codes that come in the CPT book, but there are also codes in that other HIPAA required code manual that might be needed based on various carriers. So for example, the chronic care management for patients having their mental health services overseen by a primary care provider. To some insurance companies, you'll use the CPT code, but Medicare has their own codes. Again, different billing for RHCs and FQHCs, followed by some of those H codes that I hinted at earlier were only used for Medicaid. So without giving you and reviewing each of these, because there are many more that I'm giving you on slide 33, but these are some examples, such as the H0015 for those of you that have an intensive outpatient program. But the HCPCS Level 2 manual only has 2 sections to be used and reserved for possible Medicaid use. I recommend you go look at these H codes, which are designated for substance and alcohol and opioid abuse, such as that peer support individual I talked about earlier. Maybe Medicaid has the first 2 codes they want to use for nursing assessments rather than the nurse visit CPT code 99211. Maybe you're using the T1015 code instead of your qualifying visit list codes for Medicaid. So again, H codes and T codes, I'm here to give you some options. And of course, in the full session, we do go into more detail. So as we wind our way down, folks, I emphasized earlier the differences between DSM-5 definitions and ICD-10 definitions, and whether some clinical terms do or do not show up in one of those manuals. But I do need to issue a reminder here, especially if Idaho, and I don't recall, for example, has medical or recreational cannabis use. that if documented drug use does not or is not documented as affecting the patient's mental, physical, or behavioral health, you do not code it, do not include it on a claim except in pregnancy. So clearly a septal ulcer, due to cocaine use has its own code, tachycardia. Due to methamphetamine use has its own code. So knowing what's called the table of drugs and chemicals in the ICD-10 book will be helpful. But in the DSM-5, as I talked earlier, in order to confirm a diagnosis of opioid use disorder, your providers are documenting at least 2 of the following items that were observed in the 12-month period. Noticing at the bottom that substance use disorder has a very similar list of, I think it's 11 or 12 questions here. Once they get to at least 2, that provider may have identified a substance use disorder, but when you go into the ICD-10's guidelines, section 1, subsection C, chapter 5, what you'll find is that the ICD-10 says we have to have only use, abuse, or dependence. As a matter of fact, there are no opioid use codes in the ICD-10 because, of course, they can be correctly prescribed. Opioids only have abuse and dependence, whereas substance use, or abuse or dependence, if you're documenting more than one, whether it's use and abuse, you only assign the code for abuse. If both abuse and dependence are documented, you only assign the code for dependence. We recommend you get with your providers to share some of the more in-depth highlights related to these guidelines and their difference with the DSM. And another guideline or another little good slide you might want to use for this is that in addition to substance or opioid use disorders, your providers are likely including the words mild, moderate, or severe based on these or other similar criteria. So the ICD-10 is asking us that we use abuse as the code if there is a mild use disorder, and if the provider documents moderate or severe, that you choose the ICD-10 code that references dependence in the diagnosis definition. So the most common diagnosis that I've seen here used to get opioid dependence reimbursed is F11.20. Okay, I mean, that's, opioid dependence uncomplicated. But even on the screen, folks, you see numerous more detailed diagnoses that identify additional coexisting conditions or items that used to take more than one ICD-10 code, but now would be just one, like at the bottom, opioid dependence with opioid-induced sleep disorder. These are called combination codes, and public health really would find value. Forget reimbursement. Public health is really going to find great value here in having that detail. So what I've done for alcohol-related disorders is gone through the ICD-10 to locate the detailed information for each of these categories for you to review when you get the opportunity to either take notes or look to this again. And hopefully you'll find helpful information in each one of these. But at this point in the presentation, folks, I don't want to just, read slides to you. Rather, I want to be available for questions. And it may be obvious that there is a need for ongoing, more in-depth education. But as we wind down, let me give you the remainder of the slides. But notice we've given you 2 or 3 slides with helpful information based on the substance and the potential difference in the DSM-5, like polysubstance or many substance dependence, although it was removed from the DSM, is in the ICD-10 under the category of F19. All right. So for good examples on how to turn non-specific documentation into more specific documentation, I really like the manual from Miss Bernard that comes from the AMA's bookstore. I encourage you to take a peek at it, as well as the need to include the social determinants of health diagnoses, which could impact your level of office visit when you're thinking evaluation and management. And of course, some of those social and economic issues that should never be the primary diagnosis, but rather a supplemental diagnosis, is going to help in a grant project, or could just really help you in your office get them to helpful resources they may need. Hey, they can't come for their visit twice a week. They don't have access to transportation, or they may have a difficult time during their treatment and in their recovery because they, live with other users, et cetera, et cetera. And so a good website for additional details on the social determinants of health can be found using the website at the bottom. There are like 9 YouTube videos and a lot of good templates available. So in terms of screening, let's finish up here, really summarizing what I've mentioned before and documenting those visits, regardless of which tool you're using, as long as it's approved, like the SBIRT tool that's really been gaining popularity. Here are some sample coding options for screening for substance use. And notice again, some carriers might want the CPT code, some might want the HCPCS code, Medicaid might want the H codes, and heck, there are even CMS covered services on an annual basis related to our subject. So I'm going to give you these slides here that identify that the initial assessments done could be done expressly for substance and opioid screening, or during an unrelated medical visit for back pain, or even at those preventive medicine visits or the psychiatric visits. And whether it's the screening, assessment, and interventions options, when we're reporting the induction and follow-up visits, that's evaluation and management services, plus injection codes or implant codes. And if we gave an injection, whatever the J code was for that substance. So taking these slides along with some additional helpful information from CMS and the National Association of Community Health Centers, who, although they're giving you billing rules related to FQHCs, there's wonderful stuff in here about creating referral relationships and scrubbing charts 2 to 3 days before the patients arrive to see who might need screening. We're giving you good stuff on how to document your psych interviews, how to document your therapy services. And we recognize this is a very short session, so hopefully these additional resources, like the one from the American Society of Addiction Medicine, will give you alternate views and information on the same content that we've given you, such as the appendix and somewhat of a crosswalk between DSM and ICD-10. At this time, folks, I'm going to defer to the fine folks at the Panhandle Health District number 1 to facilitate a question and answer session. I thank you sincerely for the time to speak and look forward to your participation in the Q&A section and identifying whether or not additional full training would be helpful. I thank you for your valuable time, and thank you for the valuable work you do for folks in Idaho. Thank you very much. Again, my name is Gary Lucas, Vice President at Arch Pro Coding. We'd love to be able to help you in the future if we can. Thank you.